and now I'd like to give you my talk on updates in pre-hospital resuscitation and tranexamic acid. I have no financial disclosures, but there is a disclaimer. This talk does contain several scientific studies that look at the use of tranexamic acid and plasma in the pre-hospital arena. I plan to run through these slides quickly and just deliver the take-home message at face value and not argue for or against how the study was conducted. So the objectives are to review types of blood and blood products, discuss the benefits of pre-hospital plasma. We'll run through what coagulopathy, fibrinolysis, and the mechanism of action of TXA or tranexamic acid. We'll review the crash studies briefly. We'll discuss some controversies around the use of tranexamic acid and relative to U.S. trauma care, and we'll review the TXA pre-hospital literature. So when a unit of blood is donated, typically get about 500 cc's from a donor, and that immediately goes through a soft spin, creating packed red blood cells and platelet-rich plasma. Then that plasma goes through a hard spin, and the platelets are extracted. And at that point, if the remaining plasma is frozen, that becomes, within 8 hours, it becomes FFP. If that FFP is then allowed to warm to about 4 degrees Celsius, certain clotting factors precipitate out of solution, and that is what forms cryoprecipitate. And typically, about 5 of these platelet samples are put together to come up with 1 acrodose unit of platelets that is transfused to a patient. And similarly, we get about 15 cc's of cryoprecipitate, and 5 of those 15 cc units are compiled into what we call a 5-pack of cryo. That is what we typically give to a donor. Cryoprecipitate is loaded with fibrinogen, von Willebrand's factor 8, and factor 13, which all become deficient during massive transfusion scenarios. And so a 5-pack of cryoprecipitate typically contains about 1,600 milligrams of fibrinogen, which is a critical component of forming blood clots and becomes depleted in massive transfusion and massive hemorrhage. And a 5-pack of cryo raises the fibrinogen level about 35 milligrams per deciliter. And there's no ABO compatibility issues with cryo. Liquid plasma is plasma that has been fractionated, and it does not go through that hard spin, so it still contains platelets. And it's immediately available for transfusion, and it can be stored for 26 days at 1 to 6 degrees Celsius. And the universal plasma donor is an AB negative, although we sometimes use A negative. Low titer A negative plasma can also be a universal plasma donor. So we're all familiar with the 4 blood types and the Rh factor. O positive is the most common blood type in the USA, and 37% of Caucasians, 47% of African Americans, and 53% of Hispanics, and 39% of Asians have O positive blood type, followed in decreasing order by these other blood types. And the least common blood type is AB negative, or universal plasma donor. And you can see the percentages of AB negative in the population. O negative is the universal donor, and it comprises about 6.6% of our overall population. And you can see that an O donor can be given to an A or B or an AB, and an AB plasma donor can be given to an A, a B, or an O recipient. Coagulopathy is a term to refer to blood that is not clotting normally, and this causes ongoing bleeding, and it causes bleeding from tissue that really doesn't even have injury or significant injury. And traditional causes of coagulopathy are disseminated intravascular coagulopathy from massive tissue factor release, or you can have dilutional coagulopathy if someone is bleeding and all you give them back is packed red blood cells and saline. This will greatly dilute out the clotting factors in the blood and prevent the blood from being able to clot. Also, acidosis, hypothermia, and hypocalcemia all contribute to coagulopathy. In fact, the citrate that's used to preserve packed red blood cells chelates calcium, and so the mere act of giving packed red blood cells reduces serum calcium concentration. So every 4 units of packed red blood cells that are administered to a patient, you have to give them an amp of calcium to prevent them from becoming hypocalcemic. More recently entertained causes of coagulopathy, as people have explored other possibilities in traumatic shock of coagulopathy. Tissue injury from blunt trauma can cause protein C activation, and protein C is part of the clotting cascade that helps prevent blood from clotting too much. In massive tissue trauma, protein C can become abnormally activated and cause breakdown of blood that is trying to clot. Also, the disruption of capillary membranes can release a compound that has a heparin-like effect and thereby causing coagulopathy. Fibrinolysis also occurs during massive hemorrhage when there's an abnormal activation of tissue plasminogen activator. In the bottom corner here, you see a patient that had a brachial artery injury and had severe hemorrhagic shock. And at the primary operation, we just put a shunt in the artery and took them back to the ICU where we could warm them up and treat their coagulopathy. And then they came back at a later date and had a definitive repair with a piece of vein to replace that missing segment of artery. So this will be our first study that we look at. This is the PAMPer trial, where patients were given 2 units of plasma by an aeromedical transport, and if they had a traumatic brain injury and their systolic blood pressure was less than 90 and their heart rate was greater than 108, or if they had one reading of a systolic blood pressure less than 70. So these patients were randomized to either get plasma or just saline. 13 of the 27 participating aeromedical bases carried packed red blood cells, and this was considered standard care to receive packed red blood cells. The study group was the patients that received plasma. You were excluded from the study if you were greater than 90 or less than 18 years of age, a prisoner, pregnant, had no access, or had acute spinal cord injury. And this is a more detailed list of the inclusion criteria here. And basically, they enrolled 230 patients to plasma and 271 patients had standard care. There was 73% male and 82% blunt trauma, and the median injury severity score was 23. And the overall mortality of this group of significantly injured patients was about 30%. 51% of patients received pre-hospital intubation. 35% received packed red blood cells prior to arrival, and 58% underwent urgent surgical procedure during the first 24 hours of their hospital admission. And basically, they showed that the mortality was 23% for the patients that had received plasma and 32% for those who got standard care in their pre-hospital treatment. And this was an absolute difference of 9.8% that was statistically lower in the plasma group. When they did a regression analysis accounting for crystalloid, packed red blood cells, and clustering at the base level, the plasma patients had a 40% reduction in mortality, which is quite a significant improvement. Plasma also resulted in overall lower blood products and packed red blood cells transfused. However, there was no difference in complications such as ARDS, organ failure, or their initial TEG study. And this slide just shows the overall survival. This is hours on the x-axis, and this is their survival. And you can see that the plasma patients broke out pretty early and had better overall survival than those patients that had standard care. And this study was, or this graph is from a secondary analysis of the same patient data. And if you got packed red blood cells and plasma, your survival was better than if you got plasma than if you got packed red blood cells alone or crystalloid. And so the conclusions from this study were that patients receiving pre-hospital blood products benefited the most from resuscitation in this decreasing order of resuscitation fluids. So the crash studies in 2004, the original crash study was corticosteroids for traumatic brain injury. And this basically showed that steroids actually slightly increased mortality after traumatic brain injury. And the original crash study is what stopped the use of steroids for patients with TBI. The crash 2 study, published in 2010, looked at giving tranexamic acid, an antifibrinolytic, to patients at risk for hemorrhage. And the crash 3 study looked specifically at giving tranexamic acid, the antifibrinolytic, to patients with traumatic brain injury. So a bit about tranexamic acid, TXA. It was first described in 1957, and it was used in the 1960s to treat women suffering from postpartum hemorrhage and DIC. And basically, as I commented earlier, in situations of massive hemorrhage, for some reason, tissue plasminogen activator becomes abnormally upregulated, and to break down blood clot, which is what TPA's responsibility is normally as healing occurs, the blood clot needs to be resolved. But in cases of massive hemorrhage, it abnormally becomes activated. And what happens when it becomes activated is it attaches to a compound called plasminogen, and TPA and plasminogen, when they become combined, attack fibrin, and fibrin is a basic backbone of a blood clot. And these two compounds then break down the blood clot, and this leads to coagulopathic bleeding or abnormal bleeding. Tranexamic acid blocks this receptor site on plasminogen and prevents fibrin from being broken down. And so the concerns about TXA is that it might cause stroke, heart attack, DVT, or renal failure. So the CRASH-2 study looked at 20,000 patients in 247 hospitals across 40 countries that were at risk for significant bleeding. And they were basically given a gram of TXA in the field. And then when they got to the hospital, they were given another gram over 8 hours. Or this could have been in the field or after they got to the hospital. And the patients were, the primary outcome was death within 28 days, and the deaths were all categorized by these different causes that you see here. And basically, the 10,000 patients got TXA and 10,000 got placebo, and the mortality in the TXA group was 14.5%, and it was 16% in the placebo group. And they had such strong statistical power with all of these patients that even a small absolute difference of about 2.5% was very statistically significant and resulted in a 0.9 lower incidence of death if you got TXA. And the mortality when they looked at specifically at bleeding was 4.9% in TXA and 5.7% in placebo. And so your death from bleeding was significantly lower, and you were 0.85 times less likely to die from bleeding if you got TXA, and there was no difference in thrombotic vascular occlusive events. This is just a picture of somebody who sustained a seatbelt injury to their bowel, and you can see the mesentery, which carries the blood vessels to the intestines, was damaged, and this piece of intestine became ischemic, and this part of the bowel had to be removed and reconnected to treat that problem. So this is the findings, the essential findings of CRASH-2. Basically, if you got TXA within 1 hour or from 1 to 3 hours, your mortality was better than those who didn't get tranexamic acid. If you got it greater than 3 hours after injury, it didn't have any treatment effect. And so this is what led to the recommendation that TXA, if it's going to be given, should be given within 1 to 3 hours. And we did give TXA in the helicopters on Life Force for several years after this study came out, as well as here at the hospital. But several trauma centers in the United States questioned whether this was applicable to U.S. trauma care when blood products were immediately available and surgical intervention was immediately available. And so this is at a Ryder hospital in Miami. And basically, if you got no tranexamic acid, you received less packed red blood cells at 24 hours than you did if you got tranexamic acid. And the mortality for the patients that did not receive TXA was significantly lower than the patients that did get tranexamic acid. So it led this group to be concerned about giving TXA to patients that are in a mature trauma system that has blood product availability, pre-hospital, and emergent surgical capabilities. This is the group out of Denver had a similar study where they looked at TEG studies or thromboelastograms on all of their major trauma activations. And basically, if you were a trauma patient requiring blood and your TEG showed that you were not in fibrinolysis on admission, your mortality was higher if you got TXA. So they basically found that TXA for patients requiring transfusion on admission to the hospital was bad, and it increased mortality. So based on these two studies, a lot of places, including Erlanger, stopped giving TXA unless they had a tag showing that patients were in fibrinolysis. It makes sense, right? If you're not in fibrinolysis, there's no point in giving TXA. So this is a little intermission, been doing a lot of studies. This is a patient that was stabbed in the left upper quadrant. This is the umbilicus, the head is up here. And this is his omentum has eviscerated through his stab wound. And we took this patient and we put a laparoscope in him. So we've got a camera in the umbilical area, and we're looking at the stab wound from the inside, and you can see that the omentum is herniating up through the abdominal wall through the wound. And this is after we have reduced the omentum, and that's a finger occluding the hole so the air from the laparoscopic surgery wouldn't escape. And we were able to take a couple of sutures and repair that abdominal wall defect. We ran the small bowel, and there was no injury to the small bowel. And I believe we discharged him from surgery. So CRASH 2 was another study that looked well, this is the conclusions from this study. These authors felt that tranexamic acid may increase the mortality with patients that were not in fibrinolysis, and that CRASH 2 was performed in developing countries without the same resources as the United States. And the Europeans did not use real plasma in their pre-hospital resuscitation, and they use Kcentra and recombinant fibrinogen, which don't have all of the normal anti-clotting factors that liquid plasma does. And they felt that the use of tranexamic acid may not be applicable to US trauma centers, and they recommended that you check a tag before you give TXA. And that's when this study came out, that's when we stopped giving TXA routinely. So this is the CRASH 3 results, another big study looking at giving tranexamic acid in patients with traumatic brain injury. And in this study, about 6,400 patients got TXA and about 6,300 got placebo. And basically what they found was that mortality was lower in patients with mild to moderate traumatic brain injury. That is a Glasgow Coma scale of 9 to 15, and it reduced their risk of death by 0.78. But there was no difference in mortality with patients that had severe traumatic brain injury. The mortality in the patients that got TXA with severe brain injury was the same as those who didn't. And this basically shows the a tornado plot of their findings. And basically, if you got TXA with mild to moderate TBI, this was the improvement in your mortality compared to those with severe TBI. And this graph just shows the sooner you got TXA, if you had mild to moderate TBI, then the better your mortality was. And this just shows that it had no effect on patients with severe TBI or Glasgow Coma scale of 8 or less. And this slide is just their complication outcomes. And basically it shows that there was no difference in thrombotic events, sepsis, seizures, or GI bleed between TXA patients and placebo for any time group, really. The less than 3 hours, greater than 3 hours, or everybody combined together. There was no difference in clotting complications, which is important to know that TXA really is pretty safe as far as that goes. So this is another study pre-hospital looking at patients that got TXA that were at risk for major hemorrhage. And there was 3 treatment groups in the patients that got TXA. The first was just a TXA bolus, and placebo thereafter, and this was the abbreviated treatment arm. Then there was the patients that got 1 gram of tranexamic acid and then received an 8-hour infusion of TXA after they got to the hospital, and this was known as a standard treatment group. And then there was a group of patients that got a repeat bolus of TXA when they got to the hospital and then underwent the 8-hour infusion. Their criteria were that the TXA first dose had to be given within 2 hours of injury, and you had to have at least 1 episode of hypotension less than 90 or a heart rate greater than 110. And they had similar exclusion criteria as we've heard previously. And basically, when you combined all 3 treatment groups of TXA, there was no difference between the survival rate compared to placebo. However, they did subgroup analysis and found that the group that got the repeat bolus had a statistically lower mortality than the patients that had placebo. And they also found that your mortality was reduced compared to everybody else combined if you got your TXA with an hour of injury. They also found that if you had a pre-hospital blood pressure less than 70, your mortality was greatly reduced, and the mortality was 18 in the TXA patients that were profoundly hypotensive compared to 35 in the patients that had placebo. And this slide just shows that there was no difference in fibrinolysis between the 2 groups, which was a little puzzling. It didn't appear that tranexamic acid had any treatment effect. So it's curiosity why the TXA patients had reduced mortality. So conclusions from this study were that TXA is safe. The 3 gram with the repeat bolus appears to be the most efficacious, and giving TXA early within an hour of injury or in patients with severe shock improves outcomes. This is a patient that had a grade 4 liver injury. This was a crack between the right and left lobes of his liver, and we've got all the bleeding controlled. And this is a piece of omentum or a piece of tissue in the abdominal cavity that can be used to pack this, and it reduces bile leaks out of the liver after you've had major liver trauma. So this study is out of Netherlands, and basically it just showed in patients with severe isolated traumatic brain injury, mortality was higher if they had tranexamic acid. So the CRASH 3 study showed that there was no difference in mortality if you got TXA and severe TBI. This study actually showed that there was significantly increased mortality in severe TBI patients. So conclusions for this talk: pre-hospital plasma in hypotensive patients with traumatic brain injury reduces mortality. It resulted in a 10% absolute reduction in mortality. And when you account it for patients that got packed red blood cells and did a regression analysis, it actually resulted in a 40% lower mortality for the patients that got plasma, and giving packed red blood cells and plasma was best for survival. So the conclusions and takeaway about tranexamic acid: the CRASH 2 study showed that there was a modest reduction in death for patients at risk for bleeding, and similarly the CRASH 3 study showed there was modest reduction in mortality for patients that had mild to moderate TBI. Tranexamic acid's role in U.S. trauma centers has been questioned. in the pre-hospital arena, and it is recommended that by some that you should check a TEG before you give TXA, which can't be done until the patients arrive at the facility. In patients that have severe shock, TXA may reduce mortality, particularly if it's you receive the second bolus and the first bolus is given within an hour of injury. TXA is of no benefit and may actually increase mortality in severe traumatic brain injury. So should we be giving TXA in the pre-hospital setting in Eastern Tennessee? Well, it may help for mild to moderate traumatic brain injury, but the mortality of that is really pretty low in our center, and don't know if adding TXA will help that or not. However, patients with severe shock that wind up receiving the massive transfusion protocol, TXA may be of benefit in those patients. Erlanger has 6 helicopters that can get 2 patients quickly and bring them back to the hospital, to the trauma center urgently. We have liquid plasma on board since 2016. We've been giving packed red blood cells in the air since 1990. We have immediate OR availability. We can take a patient off the helicopter and take them straight to surgery if we know that that's what they need. We have the massive transfusion protocol, which you can see one of our red shirts hanging blood on the level 1. And this is a pile of blood that they've given somebody. When you have that sort of product availability, does TXA really improve your outcomes? We started giving fresh whole blood as part of our massive transfusion protocol in 2019. And we currently do platelet mapping studies on all TBI patients. You know, we do everything that we can in the realm of treating patients with severe bleeding and traumatic brain injury to try and prevent coagulopathy and progression of their bleeds with what is pretty well proven science. And so we are still under deliberation about when and where to give TXA. We are continuing to evaluate our current status and are trying to decide if we need to use TXA in the pre-hospital arena and then include it as part of our massive transfusion protocol. And that concludes my talk, and I'll be happy to take any questions in the live session at the end. And thank you for your attention. Have a good rest of the meeting.